everybody, and welcome to week 10 of GCH 426, Emergent Infectious Diseases. I hope you all are enjoying the relatively nicer weather that we're getting here in the metro region, DC metro region. If you're not here, well, I hope that the weather is fine wherever you are. So this week we're going to talk about rabies and rabies-like viruses. I'm going to start off with some exam stats for the midterm. You all did very well. However, there were some questions that I can see gave some of you some issues, and so I'm going to go through those questions here in a second. And then, if you have any questions about the midterm from here on out, let me know. Ask me questions. And then, as we prepare for the final exam, please be aware that the final exam is completely comprehensive. So it covers all the lectures, everything we've covered so far, and some of the questions you see in the midterm will probably make their appearance again in the final exam, so be prepared for that. So let's look at some of the statistics here. The lowest grade was a 78%, the highest was a 98.5, the average was 90, the median was 91, and if you remember from your statistics, it's a pretty normally distributed curve, as you can see. If you can see my pointer, let me turn it on. If you can see the nice little normal distribution here at the top end of the curve. So you all did relatively well. You answered the questions as best as you could. There were, however, 4 of you who were late in the submission of the midterm. If you're going to be late for a midterm, for a quiz, for a prompt, anything that might make you miss a deadline, please let me know. If you let me know, we can work through it. Unfortunately, some of you did not let me know. Did not notify me about this until after the exam was graded. And so, unfortunately, I already put the answers out. I had graded everything, so the answers were back to everybody, and it's just not fair to allow any further time to finish the midterm exam once the grades are out there. So please let me know. It's in the syllabus that if you're going to be late, let me know. We can work through it. However, I cannot accept late work if you didn't notify me. So there's nothing I can do there. Here are some of the wrong answers from the exam. Vaccines are, in fact, pharmaceutical interventions. 20% of you got that wrong. Non-pharmaceutical interventions are things like PPE, social distancing, isolation, quarantine, shutdowns. Basically, anything that was not created in a lab is a non-pharmaceutical intervention. So this question can and will come up again in the final exam. So remember the difference between pharmaceutical interventions and non-pharmaceutical interventions. Pharmaceutical interventions created in a lab, a vaccine, a medication, an antiviral, an antibiotic, an antifungal. Okay, HIV causes AIDS, not measles. There were a couple of you that said that measles causes AIDS. No, that is not the case. Influenza is not bloodborne. That is not the case. It is airborne. And diabetes is not contagious, although you could make an argument that you have a higher risk of diabetes based on your family history, but then it wouldn't be a contagious disease, it would be a genetic disease. And somebody could make the argument that if you are among people who are diabetic, so if you're in a neighborhood that is diabetic, you're more likely to be diabetic. Well, it's not that the people gave it to you or that you contracted it some way through like a mosquito or some other vector. It's because of the environment. In that case, it would be an environmental disease. The question about who first brought the knowledge of aeration to the American colonies. Almost half of you got that wrong. And this is important, you guys. It's important because we need to get history right. And Onesimus, an enslaved man from what is now Libya, was brought to Massachusetts, and he was sold off to Cotton Mather. And he told Cotton Mather about this variolation that was done to slaves to better allow them to resist the smallpox epidemics that would go around. And so it's his credit right there. It wasn't Cotton Mather, when it wasn't Boylston. Boylston was the physician that Cotton Mather consulted with. So please be aware of that. Less than 1% of immigrants were diagnosed with trachoma. A third of you got that question wrong. Remember the story about the rabbi from the book, from the When Germs Travel book. Measles and chickenpox are not zoonotic. They might have arisen from a spillover event way back when, but today they are not the result of animal exposure. So today you get measles and chickenpox from other humans. You don't get it from an animal reservoir. So that is why they are now not zoonotic. The most stringent precaution is full barrier precautions. So remember in that one lecture I was talking about all the different kinds of precautions. Please review that lecture and know the different levels, I will definitely ask that question again. If you see anything greater than 10%, I will probably ask that question again in the final exam. True, a persistent infectious disease that cannot be controlled is an emergent infectious disease. 25% of you said false. No, that is true. That is one of the definitions from the first or second lecture. Type C influenza is not a public health concern. That is true. Type A and B are the ones that cause epidemics, and Type A causes pandemics. Type B, not easy to cause a pandemic because it doesn't travel well from person to person, or rather it doesn't have anything other than humans and seals. Whereas Type A can cause pandemics because it has humans, seals, pigs, other mammals to transmit it, and so that allows it for more genetic variation and for more evasion of the immune system. In the U.S., children are not given the BCG vaccine. The BCG vaccine is given in developing nations, but not in the U.S. In the U.S., we use test and treat. So that was the other question. So if you got one question right, you should have gotten the other question right. They're both complementary questions, and you'll see a lot of these questions in my exams as well. There, if you get the answer to one, that will give you a strong hint for another question. So BCG is not the preferred way to control TB in the U.S. In the U.S., we control tuberculosis to test and treat. So somebody has a risk factor for tuberculosis, healthcare workers, people working in prisons, people working in congregate settings, especially with people who have had tuberculosis. Then they are screened for tuberculosis exposure, and if they are positive in the screening, then they get treated with antibiotics. It used to be that you did an arm test, the mannitol protein test in the arm, but not anymore. Now you do one of the more, they're called IGRA blood test. We also screen people who are coming into the country from other nations, or ideally everybody that's coming in from other nations, be they travelers or be they immigrants or refugees. And no, the BCG vaccine is not given in the U.S. A second dose of MMR was used because of the epidemiological shift. Many of you got this wrong, and so I'm left wondering if maybe I didn't cover this in a lecture, but I'm pretty sure I did because I got most of these questions from the lecture slides. What happened was that after the first dose, a lot of kids were not given it, and so when they got to their teenage years, they got measles. Or mumps or rubella, and so a second dose was then recommended for older kids going into elementary school, so they would have that boosting effect, and also because the effectiveness went from about 90% to like 98%. Measles and chickenpox have not been eradicated. Remember your definitions. Definitions are also very important, you guys. So eliminated means that it's not transmitted endemically. Or there's no local transmission of the disease at a higher level, at a high endemic level in a location. There may be outbreaks, there may be epidemics from time to time, as there are in the U.S. with measles, and so that allows it to be called eliminated, but it has not been eradicated. Eradicated means that it's completely gone from the human population. Only smallpox in humans and rinderpest, a cousin of measles, have been eradicated. So please be aware of the differences between eliminated and eradicated. And no, there is no influenza pandemic currently going on. Almost a third of you said that there was an influenza pandemic going on, and I was like looking around, hoping that wasn't the case. So no, we have our seasonal epidemics, and we're still in the flu season, but we are definitely not going through a flu pandemic right now. That would be a double whammy that I do not want to deal with. An epidemic need not be severe to be called pandemic. That is true. You can have an epidemic that is going on in many countries and many different continents, and that would be a pandemic. So pandemic is not a measure of severity. Pandemic is a measure of spread. The first cases of HIV/AIDS were from detecting opportunistic infections. That is true. The first cases were reported because men who were otherwise healthy and had no other known medical issues were coming down with these opportunistic infections with fungi, and that led to finding out that their immune system was in fact weakened by the virus. So no lab testing was available at the time. True, the R naught, the basic reproductive number, can change as disease dynamics change. So the R naught for COVID, for example, can change. It can be very high if nobody's immune, and then it changes to lower if people start being immune either through infection or vaccination. And then it completely can hit zero or actually go into the negatives Well, I don't think it can go into the negatives. I mean, like you have a negative number of people coming down with it, that would be very silly. It can get to zero if it goes away, right? Like SARS and MERS. The essays. So the essay answers, you get full credit if you formulated a coherent set of thoughts. If you just put a good set of thoughts, complete sentences, then you got full credit. Because if you notice, many of them were in your opinion. So there were no right or wrong answers. If you were completely off base, or answered something not in complete sentences, that I gave you feedback for that question. So it's always going to be, it depends. This is going to happen very much in your career in public health. So a lot of answers are having to depend. They are not going to be right or wrong. So I also wanted to give you an antibiotic resistance update. There's a lot of antibiotic resistance going around in the world. Group A strep or strep throat is showing drug resistance, and that is a problem. Because right now kids who come down with group A strep, they get antibiotics that are very effective, amoxicillin among them, which are some of the first and second generation antibiotics. Penicillin, the second one after penicillin would be the second generation. And so it's happening more and more, and it's spreading, and that could be a problem later on because many kids get strep throat. I had strep throat towards the end of remember when I could barely talk, that was strep. Candida auris is a fungal infection with this candida fungus, and it is also getting antifungal resistance, and so that is causing an issue. Multi-drug resistant tuberculosis, as we have discussed, that is also spreading. Multi-drug resistant gonococcus, so people coming down with gonorrhea that is resistant to almost everything. That is a problem. That is a huge problem. There's a wave of these cases coming, moving from west to east. So widespread antibiotic use with little oversight is what is causing this. People getting antibiotics when they really don't need them, when they have only a respiratory infection. People getting antibiotics when their symptoms are not too severe or their life is not being threatened. So we give antibiotics in kids because we want to avoid a complication from group A strep that happens, scarlet fever. And so kids get antibiotics even if they're acting fine. If you're an adult, less likely to have those issues, less likely to have heart conditions based on group A strep infections. I didn't get antibiotics for my throat infection. And besides, I had already had a tough run of antibiotics for an infection late last year. And so I kind of decided to just wait and see if I developed a very high fever, if I wasn't feeling too well, then I would have gotten the antibiotics for the group A strep. But other people don't, and other people demand to get antibiotics. And so, they go to the urgent care center or the emergency room where they don't get follow-up, and they just get these antibiotics. And then they don't finish the antibiotics, so they don't finish killing everything off, and that creates whatever is left to become resistant. World travel, which we'll talk about next week, that is also one of the reasons. So you have more and more people traveling the world, bringing drug-resistant organisms to different parts of the world. And then mutations, the natural mutations that happen as the organisms multiply, divide, and go around the world. So this week we want to talk about rabies and rabies-like viruses. So this is going to be a very short overview of rabies and rabies-like viruses and why they're an issue. I'm not going to get too deep into the weeds on this one. It's going to be fairly quickly. I just recommend that you do the readings and you watch the videos, the suggested videos, but definitely do the required readings for this week. So rabies, very, very serious, 100% deadly. There have been 2 documented cases of people surviving it, but the measures that had to be taken for them to survive were really, really beyond heroic measures, and I'll talk about those here in a little bit. So it takes hours to days to develop, and it really depends on the site of the initial infection. So if you are bitten by a rabid animal, it depends on where it bites you. If it bites you in the hand or in the foot, it's going to take a while for the virus to start multiplying and going up your nerves into your central nervous system and into the brain. If it bites you near the neck, the chest, the face, or on one of the larger nerves going from the arms or the legs that connect almost directly into the central nervous system, then it's going to progress fairly quickly. It also depends on your health status. If you're otherwise healthy, it's going to take a little bit of longer because your immune system will try very vigorously to fight it off. Almost successfully, but not quite. It's just gonna go and create the disease. And it depends on how much of the virus you get. If you get a lot of the virus, then obviously it's going to be a faster infection, from infection to disease. If you get a little bit of the virus, well, it's going to be waiting until it multiplies into the critical mass of virus before it attacks you. The signs and symptoms: fever, fatigue, muscle aches, a lot like the flu, right? Headache, nausea, vomiting, gets a little bit worse. Agitation, because it starts messing with your brain. You don't know where you are, who you are. And then fear of water or hydrophobia. What happens here with the fear of water is that the individual who is affected cannot swallow, and so you're afraid of even putting anything in your mouth like water, because you can't swallow it, and so you actually develop a fear of drinking water. This is not like a fear like you see a lake and you run the other way. This is a fear of drinking the water. So very, very serious. Again, 100% deadly, very bad infection. And you see this picture from CDC of a patient who has to be restrained because they're just delirious. This is probably close to the end for this unfortunate person who is developing all the signs and symptoms of rabies. Once the signs and symptoms begin, there is no going back. It's only going to progress to get worse and worse. So I kind of skipped over the epidemiology of rabies because the problem with some of the numbers, well, first of all, it hardly ever happens in developed nations. Developed nations have controlled human rabies exceptionally well. And that is because they have been able to afford vaccinating pets and wild animals, and have systems in place where a rabid animal can be immediately, reported, and somebody goes out and gets it, and then it gets euthanized, and that's the end of that. Developing nations, however, have more issues with rabies. A lot of Latin America has done great steps in the last 20 to 30 years, and I'll talk about a case very close to home, incredibly close to home, of rabies. But they've done a great work in that sense. But you still have cases. The problem is the reporting. The problem is that the numbers are estimates, and so the highest burden is in developing nations like India, Pakistan, the Indian subcontinent in Asia, Southeast Asia, and Africa, and Latin America. Not so much in Latin America. It has really died down. There's been really a push to get control of it. And so I don't go deep into the numbers here. You can look them up, but just know that it happens to people who are in contact with wildlife, or in the larger cities where there is no control over the domesticated animals like dogs. And so that is a big issue, particularly in India. You see a lot of rabies from dog bites. It's just a big burden over there. And so even though there is vaccine, the funding and the systems that need to be put into place to vaccinate animals like dogs are not there. The virus, it looks like a bullet. If you look at it, it really does look like a bullet. It's an RNA virus from the lysovirus genus, Rhabdoviridae family. Other viruses in Rhabdoviridae can also cause flu-like symptoms, but they're not a public health concern. They're not as bad as rabies. You just get kind of like flu-like illness, and it goes away. And it's not very well known how many people get it, because as you can imagine, you develop a flu-like illness, you're probably not going to go to the doctor if it's not very bad, right? And they're probably not going to test you for this particular virus, for the vesicular virus, and so they'll just tell you to go home and sleep it off. But it does happen where people have some sort of exposure to a wild animal, and they get hit with the vesicular virus, but not as common as the rabies virus. And we'll talk a little bit about the cousins here in a second. The virus really likes nerve tissue. It is hard to grow it in anything other than something that looks like the nerves. You grow it in the lab in nerve tissue, and it really likes it. And so you can see that you get bitten. It's in your flesh, but it's going to start traveling towards the nerves, and once in the nerves, it's going to multiply really well. And it's going to have a hard time multiplying in other parts of the body, which is we'll talk about that when we talk about the vaccine here in a second. So other viruses causing rabies, so cause the disease that looks like rabies or is rabies, but not the rabies virus. So they're in the genus Lysovirus again, the Rhabdoviridae family, and you have them in Africa, Europe, and Australia. So in Africa, you have the Lagos bat virus, the Mokola and Duvenhag viruses. In Europe, you have the European bat Lysovirus 1 and Lysovirus 2. In Australia, you have the Australian bat Lysovirus 1. And there is a case there. You see the link. You can click on the link in the copy that I uploaded to Blackboard for you of this presentation. You can see the full report of a case of Duvenhag virus. Most of these are accidental infections from animal exposures. They're spillover events by their definition. You look at the book Spillover, there's a whole section dedicated to many of these viruses that come from bats. Not person-to-person transmissible, although there have been some documented cases of somebody who gets bitten by a rabid animal and then has sex with their partner, and then the partner also gets infected. Very rare and more anecdotal than anything. As you can imagine, it's very hard to really document these cases, as it is hard to just count them, right? So the vaccine, the history of the vaccine is very interesting. So Louis Pasteur back in the 1850s noticed that some infectious agents could be attenuated. They could be made less harmful. That you don't have to kill them, but you can attenuate them. They will still grow and multiply, but they wouldn't cause disease. And so he started experimenting on this 1850s, 1860s, 1870s, 1880s for 30 some years on this. And what he was trying to do, he was trying to find a cure for rabies. He wasn't trying to find a vaccine per se. And so he had a lot of rabid animals brought into his lab, dogs primarily, sometimes foxes. And so what he did is he took rabies from a dog and infected a rabbit. He knew from conducting the necropsies in the dead animals that the virus really liked the brain and the spinal cord. And so then he focused on that. At this time, they couldn't see the virus. They couldn't see the bullet-shaped virus, but they could see that the gray matter was destroyed by the virus. And so that's how he knew that it was in the brain. So he takes the rabies from a dog and infects a rabbit, and the rabbit dies. So then he takes the brain and spinal cord from that rabbit and dries it out. And then he reconstitutes it again with some saline, gives it to a new rabbit, and that rabbit dies. And he repeats this. As he's repeating this, what's going on is that he is when he dries out the spinal cord, he is selecting for the attenuated virus. He's the less hardy but more pathogenic, more disease-causing viruses are dying away, and the more hardy to the dryness and more and less likely to cause disease viruses are the ones that are being selected. So by the 20th generation, the rabbit didn't show signs of the disease. You saw this with variolation. They used to dry out the scabs from people and then grind them up and turn them into powder, and that attenuated the smallpox virus, and you were able to take it with few, if any, actual effects of the virus. Not a lot of disease from that. So he took the fresh rabies from a dog and gave it to the 20th rabbit, and the 20th rabbit was immune. And this was the eureka moment. He had figured out how to attenuate the virus. The 20th rabbit still had some signs of the infection from when he conducted the necropsy. But it didn't have the disease. It didn't show any symptoms of the disease. It showed symptoms of infection, but not the disease. And this is something that we're struggling to have people understand, that when you get a vaccine, it's not about preventing infection. It's all about preventing disease. So people get confused by those things, right? Infection means that the virus or the bacteria is on you, it's multiplying. Disease is that it's done so to a point that it's actually causing disease. So then it was time to test it on a human. It was very controversial. Do you just give people the vaccine and then follow them to see if they get rabies over time? And it was, this was the early part of science, the age of vaccines, and so it was not something that they wanted to do. But what happened was there was this kid named Joseph Meister who was attacked by rabid dogs, and the mom took him to the hospital. And the physicians at the hospital were like, he got mauled by a rabid dog. The dog was caught, and it was found that to be rabid. And so they said, Joseph is going to die in a few days. He's going to start getting the symptoms, and then he'll be dead. There's nothing we can do. This is how rabies works. And so the mom was like, well, is there anything we can do? And she had heard, or rather there had been some published accounts of Louis Pasteur doing this work on rabies. And so she took the kid to Louis Pasteur. Pasteur then consulted with some physicians. Pasteur was not a physician. He was a chemist, bacteriologist, virologist. And so he consulted with some physicians, and they said, you know what, you might as well try it, because there's nothing we can do for the kid. If he develops rabies, he's going to die. If you give him the vaccine and it gives him rabies, he's going to die. So there's it's a lose-lose situation. But if you give him the vaccine and it works, you might save him. And so what he did was that he started with the brain material from the 19th rabbit on and worked backwards over several days. So he would take the material from the 19th rabbit, virus very attenuated. He actually put it into Joseph Meister's abdomen through an injection. The virus would then elicit an immune response in the belly, in the abdominal cavity, but not cause an infection because it was pretty far away from nerves. At least that was the hope. And then over a few days, he would start giving stronger and stronger versions of the virus. Right, he was working his way back from the rabbits. And by the time that he got the first rabbit inoculation, Joseph was immune, and he never developed rabies. So this was a quite a success. Pasteur got all sorts of accolades. He got all sorts of awards for this discovery, because rabies would finally be controlled. It wasn't to be cured, but it would be brought under control, because the vaccine was then available for people who were bitten. And it was also made available for domesticated animals, both large and small, to prevent them from ever getting rabies in the first place. And that began the end of rabies in developed nations. But it's still out there. So here in the United States, you can see we have skunk, fox, and raccoon. In Puerto Rico, there's mongoose rabies. And so these are different lineages or different strains of the virus. If you look at the raccoon strain over on the East Coast, it is kept in check by the Appalachian Mountains. So apparently rabbit raccoons will not go over the Appalachian Mountains. But then you have the skunk, which is kept in check by the by the Rocky Mountains in the west, and by the Mississippi River Valley on the east. And then you have the fox in the desert areas in Arizona, and then you have skunk, a different skunk in California. You have fox in Alaska, and mongoose in Puerto Rico. So it is a very rare. In terms of, if absent the vaccine, would we see it? You would see it everywhere. But a lot of states spend a lot of money into dropping vaccine baits all over their territories, so that the animals will eat the vaccine and become immune that way. And so it really has made an impact. And we don't see, like I said, we don't see in developed nations like the United States, Canada, Europe, some of the Japan, Australia, you don't see a lot of human rabies, because that was one of the primary ways of that happening. Another way would be for a raccoon to get into a tussle with a domesticated animal like a dog or a cat, and then give them rabies, and then they would give it to their masters. So, this is something that has been brought under control because of widespread vaccination. But however, you don't want to give the vaccine to everybody. We don't have it on the schedule for growing up. It's just too immunogenic. You give it to those people who are high risk of exposure, like veterinarians, animal control people, etc., veterinary technicians, just as a prophylaxis. But you don't generally give it to the whole population, because it by immunogenic, it causes a big immune response, and it can cause a lot of side effects, unintended side effects. And so you're taking the gamble when somebody gets bitten by a rabid animal. You give them the vaccine, because it's better for them to have an immunogenic reaction than to develop rabies. Obviously, right? They're going to die from the rabies. They might not die from the immunogenic reaction. So developing nations still use the Pasteur method, where they make the vaccine by drying it out and attenuating it, and then putting it into people's bellies through injections. And this kid on the right is me. As you know, I grew up in Mexico, and this is me, around 6 or 7 years old, and I was in Little League baseball. And one day I was walking out of my house, and there was a dog in front of the house that was super angry. It was barking, and it seemed very angry. And I put my hand out to have it, you have the dog sniff your hand like you're a friend. And instead of sniffing my hand, he just bit it. He mangled my hand pretty badly, and then ran away. And when my dad came out, and he and his brother and a neighbor chased after the dog and caught it. And the animal control found that the dog was rabid, had rabies. And so off I went to the clinic. My dad and mom and dad, they, it's a death sentence, right? If you don't bring it under control right away. And the animal was pretty slobbery. It's through the saliva that it transmits the virus, because the virus gets into the brain, and then it triggers the nerve centers to create a lot of saliva, and then it travels into the salival glands, and that's how it transmits the rabies through bites. And so my hand was, I remember it was bleeding so badly. My dad took me inside the house and washed it up, and then he handed me over to my mom and went after the dog. And so they took me to an anti-rabies center. So Mexico had a lot of anti-rabies centers all over the nation, precisely for these things. They had a lot of rabies vaccine available for both animals and for people who were bitten by animals. And it didn't matter if the animal was rabid or not. If you got bit by a dog, you got the vaccine. And so they started me on the first dose. They put the injection right into my belly button. It hurt a lot. I still remember. I remember all of this. It was that traumatic. And then my dad and uncle and a neighbor caught the dog, and they brought it into the same center, and they said, yes, the animal does have rabies. He's going to have to come in. Me was going to have to come in. That was at day 0. I had to come in at day 1, so the next day, and then at day 3, at day 7, at day 14, at day 21, to get a series of vaccines. Each vaccine was going to be a stronger and stronger dose of rabies. So the first one was just to control to begin the process of some immune response quicker than from the bite. And then they also injected me with antibodies against rabies in the hand. So those antibodies would hopefully attack any virus in my hand, but not the one in the abdomen. And then the next day, and then a few days later, and then a few days, I remember every single day, because the pain was so bad from the injections right into the belly button, as you can imagine, and they had to pinpoint accuracy around there. And then at the end of it, I did not develop rabies. The dog did end up dying a few days after it bit me. They had it in the anti-rabies center. It was also an animal shelter for street animals, and they notified my parents when the animal passed away from rabies. And so you can imagine my mom and dad those days, a lot of prayer and a lot of worrying over what was going to happen, and a lot of checking my temperature and making sure that I was okay. And the minute I spiked a fever, they would take me to the doctor. I didn't have a reaction from the injections. I don't remember, and my parents don't remember either, because they checked me for fevers. They said no, and after 3 weeks, I was fine. After a month, I was fine, and then by month number 2, they cleared me. I was not going to develop rabies. So very, very personal story for me, growing up in a developing nation and having that happen. This happens all the time. It happens all the time, every day, perhaps in the thousands all over the world. And many of those people don't make it because they don't have the availability of having the vaccine. They don't have access to these kinds of centers. Again, Latin America had all these centers, and that's why they managed to bring it under control so successfully, but not everybody, as we have discussed in other classes, right? There is a lot of these emerging infectious diseases around the world travel hand in hand with things like poverty and social economic strata. So vaccinating wild animals and pets are the best prevention. Staying away from wild animals really, really helps. But it still happens in places where wild animals meet pets, and pets meet their owners / masters. And so it still happens, and it's pretty sad that it still happens with such a successful intervention as a vaccine, keeping people from developing full-blown rabies. So with that, I'm going to give you some reminders. For this week, optional viewing, The Deadliest Virus on Earth. There's the link to it on YouTube. You are required to read Rabies Virus from Trends in Microbiology. It's a couple of pages and not too long. And then The Rise and Fall of Rabies in Japan, A Quantitative History of Rabies Epidemics in Osaka Prefecture. And so this one is really good because it talks about what the effect of the vaccine was on rabies in Japan. So again, these are required readings. Please read them. A couple of questions will be coming out of those for the final exam. From Spillover, Part 6, Going Viral. And then quiz number 4 opens on the 27th, which is when you should be watching this video, which is the Monday, unless you're watching it later in the week. But it was open on the 27th, and it's due at the end of the course. Reminder: if I mention a quiz, and if it's mentioned in the syllabus, and you don't see it on the assessment tabs, please do not assume that it doesn't exist. Email me. It's probably somewhere in Blackboard. I just put it in the wrong place or under the module, which was the case with quiz number 3. So if you went and saw the lecture and you downloaded the slides, right under that was the quiz number 3. So please do not forget, there is a quiz number 4. It does exist. If you can't find it, tell me. I'll help you find it. Okay, next week we're going to talk about land use, climate change, and globalization. Optional, you can watch these videos when cities were cesspools of disease and the effects of urbanization and health disparities. So urbanization, good and bad, right? Urbanization brings you sewers and water systems and hospitals and medicine and technology and advancements. But also those cities are growing into places where there's wildlife and there could be spillover events. They are causing overcrowding, which leads to more contagion, right? We saw that with COVID, where overcrowding really led to more people getting sick than in places that were not as overcrowded. So please, if you have a chance, watch those. Those are optional, but required reading: Communicable Disease, Information, Health, and Globalization in the Interwar Period. A few pages. It's 813 to 842. It looks like a lot of pages. It's not really that long. It's a quick read. And then from Spillover, 13 Gorillas, and from Germs to Travel, No One's Idea of a Tropical Paradise, Haitian Immigrants and AIDS. When we talked about cholera and we talked about HIV, this chapter from when Germs Travel will be meaningful. And the discussion prompt number 6 will be given in the next lecture, and that one is due April 16th, 2023. So you'll have a couple of weeks to answer it. So again, if you have any questions, please let me know. If you expect to see something and you don't see it, let me know. Please keep communicating with me. If you're going to be late in any of your assignments, let me know. We can work through them. The worst thing you can do is not let me know, and then after the fact, try to explain to me what happened. It just doesn't work out, because I put out the answers to the quizzes or the exams, and then it's not fair to everybody else who did their work on time. So with that, thank you so much. I hope you are staying safe, and we'll talk again next week.